we're going to learn about this today, this week. We're going to learn about cystic lesions of the pancreas. Okay? And the thing I want you to take away is that they're not unusual. They can happen. They are common. We're not talking about pseudocyst. We're not talking about cyst that is a sequelae of alcohol. Okay? We're talking about true cysts. What does that mean? Cysts that have an epithelium. Pseudocysts have no epithelium. Okay? That's why it's called pseudo. Okay? It's just fibrotic tissue surrounding the inflammation, the body trying to contain the toxic fluid. That's a pseudocyst. Cystic lesions of the pancreas, true cyst from epithelium. Why does it happen? We have no idea. Yeah, I think it's God's gift to HPV surgeons. You're going to see these cysts incidentally found. What does that mean? Out of the blue, they've been worked up for something else, and there's a cystic lesion or a solid lesion. Okay? In general, any lesions of the pancreas that is a certain size needs to be removed. Okay? You can sit there and ruminate and say, well, is it this, is it that? It doesn't matter. If it's, to me, if it's 4 centimeters or greater, or if you're washing it and it's growing, okay, they need to be removed. The diagnosis is made after the fact. Obviously, if the patient is not in good health, or the patient has other comorbidities or other reasons that you can't take the patient to the OR, that's different. But if the patient is healthy, the patient is otherwise have no other issues to be concerned about, lesions of the pancreas, to me, 4 centimeters or greater, need to be removed. Okay? Here's a whole litany of cystic lesions, but the way I want you to look at it is the bold face. Okay? You can put them into 4 categories. They can be serous cystic tumor, mucinous, IPMN, or solid pseudopapillary neoplasm. There are other very rare variants. We're not going to talk about those. Okay? We're going to think about those 4. If you break it down, okay, of the 4, they all need to be removed except 1, which is a serous cystic tumor. And even those, we remove them because they tend to be big. Okay? I'm going to go over some of the key elements that you can see on images that can help you decide, this is likely to be a serous cyst adenoma. This is likely to be IPMN. But the reality is not 100% foolproof. There are lesions that I was convinced it's a solid lesion, that it is cancer. Turns out to be something else. Benign lesion. Okay? And there are lesions that I believe, this is probably serous cyst adenoma. Turns out to be cyst adenocarcinoma. So what I'm saying to you is that today, for the next 10, 15 minutes, we're going to go over radiologic readings of it. But keep in mind that they're not 100% foolproof. The definitive diagnosis is to take them out if they are a certain size and the patient can tolerate it. So how do we evaluate these patients? Generally, they're asymptomatic. Generally, they're incidentally found. But here's a slew of diagnostic tests that you can use. CT, MRI. Nowadays, if there's any question, we do EUS with a biopsy aspirating the cystic fluid. We analyze it using the CEA. Generally, the cutoff is if it's 100, if the CEA is greater than 192, okay, then it's mucinous. There's some question whether we should send it off for KRAS mutation, but it hasn't borne out to be very useful. Any questions whether we're dealing with cancer, questions that maybe there are other lesions in the lung, the liver that we could detect on the CT, we're not sure, PET scan will be helpful. But if we don't believe this is to be malignant or metastasized, we don't do PET scan on everyone. Okay? So First entity, this is a typical serous adenoma. Generally occurs in elderly women. It has a cystic, multicystic, okay, honeycomb appearance. That should be microcystic, not multi. Microcystic honeycomb appearance. So if you hear the word, this is a honeycomb appearance on the CT scan, as you can see, that's serous adenoma, okay? But look at the size. I told you it's benign, right? But because of the size and it's symptomatic, we take them out, okay? You generally can see a central stellate scar. Okay, you see it on the CT as well as on the final. If you see that, that's a serous adenoma. Mucinous. You have a thick cyst wall, smooth boundaries, okay? And the key is it does not communicate with the main pancreatic duct, okay? Eggshell calcification. When you hear the word, this is a lesion with an eggshell calcification, okay? It does not communicate with the pancreatic duct. That's a mucinous lesion. The next workup would be what? An EUS and aspirate. What are you looking for, Nick, when you aspirate? Yeah, but what else? CEA, what level? Exactly right. You're paying attention. Thank you. Right. So if you see a lesion like this, eggshell, mucinous lesion. Let's confirm it. EUS, aspirate, CEA, greater than 192, pretty diagnostic. Should we send for KRAS, Ron? No. As long as you know that some people do, but you're also aware that it doesn't really help, okay? Here's a mucinous neoplasm, okay, that we resected. I told you we're not going to hit it right. Do you see eggshell calcification? No. It's a solid mass. To me, this looks suspicious to be cancer. Okay? It could communicate with the main pancreatic duct. It's right there. Right? We did an EUS. CEA was normal. We resected it. Turns out to be a mucinous neoplasm.
Can you point it for a student? Where the
Oh, I'm sorry, right here.
Let's turn off the lights because.
Okay. Oh, how do I do that? House?
House maybe. Yeah.
Okay.
Yeah.
We need soft music or anything? Up to 7?
I think you don't want to go to Zen State. You know?
Okay. Does that look good right there? Can y'all, okay, you see this? To me, this looks like a solid tumor. To me, I was convinced this is cancer. We did a PET scan, PET was negative. But it's mucinous lesion, okay? With some dysplastic features. Here it is. We took it out. You can see the mucin here. See this? We're going to talk about IPMN. I think this slide is very helpful. IPMN can be broken up mainly into two types, okay? Side branch, main branch, okay? Main branch needs to come out regardless. And we're going to help you, show you how to detect what is main branch based on CT and MRI, okay? Side branch is basically coming off of the side. You can wash those, except there are features we'll talk about where they need to be resected, okay? As you can see, main duct, here's the MRI of the main duct dilated. Okay, you can have segmental. In other words, only segment of the main duct. Or you can have mix. Okay? But you can break it down into two categories. Main duct, which can be segmental, or side branch, or you can have mixture. Okay? Got it? If you see this picture, okay, and they show you a CT, okay, of let's say of this, and they say on ERCP, this is what they found. Diagnostic IPMN. Mucin coming back, okay? Diagnostic of main duct IPMN. Because you shouldn't see mucin if it's side branch. Okay? Here it is, IPMN, polysegmental, main duct. Here it is again, main duct, resect. If it's side branch, you resect. If you see dilatation of the main duct greater than 1 centimeter, if there's any solid component, if there is a mural nodule, patients have pancreatitis, likely secondary to that. If it's 3 centimeter or bigger, or you're suspicious based on cytology. Notice we have very low threshold to operate. Why? Because if you follow these patients long enough, you watch them, they develop cancer. And when they develop cancer, their mortality drops, their mortality increases dramatically. Okay? So these are pre-malignant lesions, okay, where we don't sit there and watch it and ruminate and wonder and drink coffee and tea and discuss it. No, these things, if in a fit patient, main branch, you need an operation. Cystic lesion that is, to me, 4 centimeter greater, need an operation. Okay, everything else, we watch very carefully. Okay? Solid pseudopapillary tumor. They're very rare, generally in women, generally in the tail of the pancreas. Okay? You see a peripheral arterial enhancement and central calcification. This one doesn't have central calcification. These, they tend to be big by the time we see them. As you can see why. They're the tail. They don't cause symptoms until they get a little bit bigger. Here's another one, solid pseudopapillary tumor of the pancreas. That's what they look like. This is the drawing. That's what they look like. This is a patient of mine, right there in the head of the pancreas. Look how big and ugly that thing is. What should we do, Eris?
Take it out.
Observe? Okay. Take it out. There it is. She was a school teacher. She did very well. So this is kind of an overall of what we see, of what that we talked about. We ignore the pseudocyst, but you can imagine pseudocyst also. What occurs here? Pennington?
You get splitting.
No. What entity occurs in the tail of the pancreas here? We talked about cystic lesions today. Let's concentrate. Solid pseudopapillary, right? Solid pseudopapillary can occur here, right? If you see something like this in the main branch here, what is that? IPMN main branch. If you see little cystic lesion outpouching here, side branch, right? All right. If you see honeycomb here, bunch of berries, serous adenoma, right? You there? All right.
Dr. Chu?
Yes, sir.
Sir, just a quick, have you also come across, I've seen questions in which they didn't do the mucin at the papilla, they said fish mouth appearance of the papilla.
What?
A fish mouth appearance of the papilla.
I don't know.
Okay. I was just.
What is that?
It's a IPMN.
Okay.
I don't know whether it's a.
They use a similar picture of that too when they show the analogy.
Yeah.
You can actually see it.
So they didn't give the mucin at the papilla. They gave the papilla looks like fish mouth appearance, and the diagnosis is.
Good to know. So fish mouth, okay? IPMN.
If you go back to that picture, I think maybe
Which one?
just the one with the mucin on it. The one of the ERCP pictures.
Oh, fish mouth?
Yes, yeah, fish mouth.
I don't know. That to me, it looks like a fish eye.
Yeah. No, without the mucin, I don't know.
That could be also the Eye of Saruman Hobbit.
Right. A pathologist would probably say some kind of fruit,
Yeah. But yeah, that's just what I'll.
Fish mouth, okay?
It is there? Ron, is there?
Yeah, it's fish mouth.
Fish mouth, okay? So if you see a fish mouth, that's pathognomonic of main duct IPMNs, okay?
Keyword, buzzwords. Yeah, and you know,
So this is what? Serous adenomas? Centrostellate. Okay. Centrostellate scar. Good. Where is this thing? Micro. Well, you see the blue thing there? Okay. Honeycomb. Okay. Microcystic honeycomb appearance. All right. You see that? Boom. Serous adenoma. Treatment. Resect. Pretty big. You can't rule out cystic adenocarcinoma. Okay? There it is. That's the answer. A, what is that? Side branch. Side branch what? IPMN. The right side. Mucinous, right? Or it could be what? Right, solid SPT, right? Solid pseudopapillary tumor of the pancreas. Right? Probably not though. I'm probably wrong. B is probably wrong. B is mucinous. A is correct. You see what I'm saying? They're difficult sometimes to diagnose based on CT scan, MRI, whatnot. But at least you get an idea of what they could be. Okay? What is this? Main branch IPMN, right? Students, you got it? Look at this. See the dark side? Darn it, this thing is
The pointer is
right here.
black remote that has a red button on it. Maybe up
Where is it?
to your left.
No, to your left.
Okay.
He doesn't have to use that technology.
I'm a disoriented Oriental.
Power button kind of.
Where?
Yeah, right there. It's working out.
Where? Right here? Oops. Wow, it moved on its own.
It's that green button. Here you go. That green button right there.
Where, the green? Can you see? Oh, okay. Right here. You know? I can say this, okay? But if you ever ask an Asian for directions, okay? The typical is not going to be, well, you hit East 70th, make a left to Piermont. You're not going to get, okay? You see that restaurant there, that Chinese restaurant, okay? It's right next to McDonald's, okay? You turn to the right. It's always relation to buildings and food chains, okay? Pay attention, you see. Okay?
Don't forget Indigo.
That's the reason why when people give me directions and they tell me, you go down to East Piermont, I don't understand what you're talking about, okay? Tell me what restaurant, what building is it near? It's near the, right, exactly right, okay? All right? All right, so this is what? This is main branch, okay? What's the treatment? Total pancreatectomy, okay? If you're suspicious, this could be mucinous, what do? EUS, aspirate, CEA greater than 192. Got it? There we go. What is this? Serous cystadenomas, right? Honeycomb, pretty big. Observe. Take it out. Right. Reset. What is this? You guys. That's it. I see greater than 90 percentile on the in-service score next year here. Got it? Let's see if it's right. Main branch IPMN, resect. Okay. A, what is A? But look at this thing here. What the heck is that? It ain't a stone, I can tell you that. It's a nodule, right? So it's really a side branch, I think, but it's a nodule. So what do you think it is? Resect, right? One indications of side branch is you have nodule, solid, or if dilatation of the pancreatic duct greater than 1 centimeter, or the patient has pancreatitis symptomatic, okay? Those are patients that you resect, okay? Now, I'll email you the PowerPoint that you can look at before the test, go over real quick, okay? Boom, 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 okay? Now, some of the slides I got from the internet, so please do not circulate it around. Okay? Some of the slides are mine, some of the pictures are mine, but some of the others are from the internet that I use. Here? Maybe segmental? Maybe this is segmental. Tough to know, right? But guess what? I think they all need to be resected. I told you, we have very low threshold for not resecting. All kidding aside, these are serious stuff here. This is really serious stuff. If you miss it, you watch it, patient comes back, develop cancer, you haven't done the patient a service. Okay? What about this? Yeah, or mucinous, I don't know. Okay? Look at this. Right. But if they came to you, let's say this is an asymptomatic patient, this is what you saw. You work it up, but what do you think it's going to need to be done? Resect, right? This thing, who would observe? Medically fit patient, that needs to come out, right? There it is, solid pseudopapillary tumor. Any questions? Yes, Eris.
For abs, I know with clinical practice resect, but they always, like Cameron's will say 3 to 4 centimeters or 3 centimeters side branch IPMN. You can observe.
Right.
Now, I guess my question is, if we get that question on abs side, asymptomatic side branch 2 centimeter.
What was the indication for resecting side branch?
Side branch greater than 3 centimeters, main duct dilation, and
Liver nodule, solid component, patient have symptoms such as pancreatitis. So the patient that's asymptomatic, 2 centimeter side branch, what should you do?
observe that one.
Right. Okay. Here it is.
And I think they will give you scenarios of older folks too, 78 years of age,
Right.
in a side branch less than 3 centimeters. It's clearly in scenarios like that you could monitor and observe if patients now are fit to have taken care of themselves.
Right. They have a patient's elderly, comorbidity, whatnot, okay? But if they give you a patient that's otherwise very healthy, medically fit, then you should consider it. But like I said, my cutoff is 4 centimeters. Anything less than that, you can watch. You can do diagnostic workup. If you're going to observe, you should be very, very careful and do thorough workup and follow these patients carefully. 3 to 6 months, interval, CT, MRI, whatnot, okay?
And actually, comorbidity is not the only issue when you come to older age. It's the natural history of this one. If the patient will live longer than the tumor. I mean,
Right.
the patient may die in 2-3 years, and the lesion may not change to a malignancy in 8 years, 10 years.
Right.
So that you have to consider.
Right. The object is not to cure patient to death, okay?
Do you EUS every, is it going for the EUSing everything, or is it mandated that you do it?
No,
if
you
you're
don't.
suspicious, or is it just kind of?
No, it's the role of EUS. I mean, a lot of places, a lot of tertiary places will do EUS for these lesions, but it is not necessary. For instance, that honeycomb appearance, you don't need EUS, because EUS is not going to tell you anything that's going to be helpful. EUS is going to be helpful in lesions that you think may be mucinous or serous. You're not quite sure, and they're small. And so you're saying, well, it could be IPMN, main branch or side branch. Now, the stuff that I show you, clear cut. But as we know in medicine, a lot of times it's not clear cut. So a lot of times you see there, I'm not sure, that could be main branch. I think I saw a nodule. Well, let's get EUS. And then those of you who show up to our weekly HP conference, you see that what we see here is just not clear cut. Okay, on top of, there are multiple comorbidities and there are socioeconomic issues, lack of access. They also have findings that are not very clear cut, and that's a challenge. Okay.
The main advantage of EUS is the depth of penetration of the lesion to the vessels. Because if we have any doubt that is resectable or not, that EUS will be helpful. Because if it's not resectable, you go there and resect it, you have not done a favor to the patient.
Okay. Any other questions?
I was just going to ask I think it was the second or third slide where you talked about serous cystadenoma.
Mm-hmm.
It also shows CEA above a certain number was cystadenocarcinoma, I think. I was just going to see if there's anything else pertinent or 6,000. On the next slide, for mucinous cystadenocarcinoma, if there's anything like test points to take from that.
Yeah. If you have a very high CEA, that's cystadenocarcinoma. Okay? Like I said to you, some of these cystic lesions, they're very difficult to separate from malignant. Okay? That serous cyst adenoma, the honeycomb, the big one, okay? It could be cancer, and the diagnosis of cancer is really after the fact. Yes, you can get a CEA greater than 6,000 whatnot, but unfortunately these are rare entities, and unfortunately by the time they present with cancer, they have distant disease. Rarely are you going to have a serious cystadenocarcinoma that has not metastasized, and they generally occur in the elderly. So the diagnosis of cancer is sometimes made after the fact. Okay? Any other questions? Yes?
Just one comment. We didn't mention about a book here today in 30 minutes. Which book is that?
It's coming out, right? So be on the lookout. Dr. Zamar and myself and 4 other editors are editing a major textbook on HPB. I think hopefully by October we should have it, and hopefully that would help everybody in this residency, in this institution, as well as in the nation and the world, to kind of look at the HPB under one big umbrella. And so we have 6 sections: hepatic, biliary, pancreas, transplantation, trauma, and innovation technology. And all deals with HPB. Okay? So you're not going to have brain trauma in the chapter, okay? So next week we're going to talk about peanuts. Not the one that you eat, but peanut. Okay? Neuroendocrine tumor of the pancreas. P-N-E-T. Okay? All righty. You laugh, but at our meeting we will talk about, well, what do you do with these peanuts? Okay? Residents and students are like, what? Why are they talking about peanuts?
Peanuts.
Peanuts, right.